Hi everybody, this section is on pain management for the EMT recert. Without further ado, let's get started. As usual, I'm going to let you read the objectives to yourself. So, a lot of studies have shown that paramedics interviewing patients are reluctant to administer opioids in the absence of obvious signs such as a deformity or changes in vital signs. A lot of people are preoccupied by the potential for faking it, looking for behavioral clues to try to indicate the severity, even ambivalence about the degree of the pain, or fear of masking diagnostic symptoms, and in some cases aversion of aggressive dosing of opioids. The big takeaway is that pain is what a person says it is, and it exists whenever he or she says it does. It's not routinely provided for a lot of reasons, just as I had mentioned. But the pre-hospital protocol should always require some sort of an assessment of pain severity, how you reassess the pain level after each and every intervention, and then documentation of what those interventions were. So even though it is not routinely provided, it is something that we definitely need to consider. So let's talk about the tools for pain assessment. You need to remember that a pain severity score does not identify a patient's desire for the analgesia, but rather the score serves as a means of establishing a baseline for the severity in order to compare trends and evaluate the efficacy of the interventions that aim to alleviate pain. So we want to use the same scale to assess and reassess. We want to interpret the signals that include not only physiologic but psychological, emotional, and behavioral interpretations. And we want to make sure that we document appropriately. So the presence of pain, the intensity of that pain, and then the change in the pain severity with time and treatment. Again, we're looking to try to create a benchmark so that we can create a trending process for patient care. So there are several types of scales that are out there and available for our use. The one that we're most familiar with is considered the rating scale or the numeric rating system, and this is a pain scale of 0 to 10, 10 being the worst pain you've ever felt in your life. It's proven to be more reliable in our trauma patients, but we also have a similar scale, typically referred to as the Wong-Baker facial response scale, that actually is really good for our pediatric patients, and you can see that listed here at the bottom of the page. But this would be considered a graphic scale. So our clinical protocols for pre-hospital pain management must list clear indications and contraindications for each form of analgesic intervention. They should be in accordance with protocols from local and regional trauma centers, and there needs to be a consensus of opinion and acceptance by receiving physicians. So a lot of the times the clinical protocol for pre-hospital pain management is handled in a realm that is well outside of what we do on a daily basis out in the field. We don't know the background or the backroom history of what it took for those protocols to come into your hands and be there for you to utilize. But this is the steps that are gone through prior to it coming out and released for our use. We need to also consider non-pharmacological interventions for pain management. So this talks about the careful use of appropriate wording, distraction away from painful stimuli. Having the parent's presence will typically reduce the level of distress in infants and children, so that's something to consider for our pediatric area. And traditional interventions should also be provided, and that can include immobilization of fractures, elevating an extremity, applying and utilizing ice, and also padding of the spinal immobilization. But analgesia should be considered prior to splinting due to the exacerbation of pain prior to the manipulation and positioning to get them on that splint. The other thing to remember too is that cold water does reduce pain, but it should be ceased or stop efforts after 20 minutes in order to prevent the chance of hypothermia. Also, some future therapies that are out there that may be incorporated into the pre-hospital realm probably well after I'm retired, but they'll be out there for you guys, would include the use of a TENS unit for acute pain relief. So let's take a few minutes and talk about our pediatric management. As I mentioned previously, the Wong-Baker faces are utilized quite frequently to try to help in assessing pain in that self-reporting pain scale. But patients at either end of the spectrum, whether they're the geriatric patient or the pediatric patient, are at risk of inadequate analgesic care in the pre-hospital setting. And inadequate therapy in children results from, typically it's the result of difficulty in assessing the pain through the communication. But that also happens again in the geriatric population as well. So maybe they're hard of hearing, or maybe there's a language barrier, an articulation barrier that causes an issue, and then we have concerns in giving appropriate amounts of analgesia because we were not able to assess them as a result of the communication barriers. But we want to optimize the environment. We want to make sure that we combat anxiety and reduce pain by improving the physical environment, and utilize some sort of self-reporting pain scale. You know, show them the Wong-Baker faces for our pediatric patients and let them point out which one most represents how they feel. Now this is called the Oucher Pain Scale, and you will note on the Oucher Pain Scale that it breaks it into ethnicity as well as cultural, and it's really kind of important that they look at the Oucher Scale as something of value because both gender and ethnicity are associated with disparities in the care of patients, particularly when you look at our adult patients. The females and non-Caucasians that complain of abdominal pain are less likely to receive analgesic support for that pain. So again, the Oucher Scale is more specifically associated with children, but it's important to understand that there is an ethnic and a cultural difference in how the analgesias are given and the care that's associated with these types of patients. So it may be appropriate to utilize this for our pediatrics of different colors. Now this is another non-self-reporting pain scale example utilizing the present history and the physical exam. So it's called the Flack Scale, and I'll give you a minute to kind of review that, but it looks at specifically the face, legs, activity, their type of cry, and then how consolable are they. And this is another common one that's out there, and it's looking less at the self-reporting, more at utilizing the history and what you find in the physical exam. But a big idea for non-invasive pain management includes the distraction. Keeping the kids preoccupied or occupied with something else helps take away some of that anxiety and reduces the pain. So we're looking at distraction here. The most common thing that we have on the truck that's available to us is going to be that glove. We can blow it up, tighten a knot, and then we can draw on it. The kids become really fascinated with that, and it keeps them entertained. And the one other area that we don't want to forget about is our neonatal patients. Our neonates can experience pain just as much as an adult, a geriatric, or a child. And ACEP looks at reducing pediatric pain and anxiety, and they're looking for research into neonatal care for pain management that specifically focuses on the risk versus benefit, and they're looking at medications such as the anti-inflammatory meds as acetaminophen and ketorolac, or Toradol if you will, also opiates, and then looking at the regional anesthetics and how they work with a neonate's metabolism and the body composition. So this is it for the presentation on pain management in the pre-hospital setting. If you have any questions, please feel free to reach out to me at any time. I'd be happy to talk to you about anything that you have. There's lots of resources that are available to you out there in the field and online. You can pull up a lot about EMS in children, and you can even look that up on the wvoems.org website and find out all kinds of information about pediatrics and how we can better assess and treat those patients. So if you have any questions, let me know. Otherwise, we'll see you again. Thanks.